Hello, my name is Tom Buchholz, and I have the pleasure today to moderate today's tumor board discussion. And first off, I'd like to introduce a truly outstanding multidisciplinary panel who's going to be talking over our cases today. First, I'd like to introduce Dr. Frank Vicini. Frank's representing radiation oncology. Dr. Vicini, can you tell us a little bit about yourself?
Sure. I'm based in Michigan. I'm fellowship trained in breast cancer radiation therapy, been involved in clinical trials through the National Cancer Institute and even internationally. So my focus is on early stage breast cancer and reducing long-term morbidities.
Thank you, Dr. Vicini. For our surgeon today, we have another national thought leader in breast cancer, Dr. Terry Mamounis. Dr. Mamounis, would you care to introduce yourself, please?
Yes, thanks, Tom. Terry Mamounis, I'm a breast surgical oncologist based in Orlando, Florida. Direct the comprehensive breast program at the Orlando Health UF Health Cancer Center. I also work with the NSABP and now NRG Oncology as the chair of the breast cancer committee, and have been in the business of designing and conducting clinical trials for almost 30 years.
Thank you very much, Terry. And representing medical oncology, we have Dr. Ruth O'Regan. Ruth, would you mind introducing yourself, please?
Yeah, hi, I'm Ruth O'Regan. I'm a breast medical oncologist from the University of Wisconsin, also Deputy Cancer Center Director of the Carboplatinum Cancer Center. And my area of interest really is in clinical trials in resistant breast cancers, including triple negative breast cancer. So I'm very happy to be here and look forward to discussing these cases.
Thank you, Ruth. And finally, the fourth panel member representing diagnostic imaging and radiology is Rennie Butler. Dr. Butler, would you introduce yourself, please?
Hi, and thank you. I'm delighted to be here as well. I am a diagnostic radiologist with a specialty in breast imaging at the Yale New Haven Hospital and on the medical faculty of Yale School of Medicine. I'm also participating in clinical trials. My main area of interest is digital breast tomosynthesis, which is a relatively new technology that has made mammography a better test, as well as breast MRI. And I look forward to discussing these cases with the panelists and learning from each other.
Thank you, Dr. Butler. Move on to our next case. The next case is a postmenopausal woman who's presenting with more locally advanced right breast cancer, again having this triple negative disease, which is estrogen receptor negative, progesterone receptor negative, and HER2 oncogene negative. This has an unknown BRCA presentation, and Dr. Mamounis is going to go over kind of some of the presenting features of this case, and we could talk about treatment.
So this is a patient that found a palpable right breast mass in the upper outer quadrant, has a good performance status, history of hypercholesterolemia and seasonal allergies, and she's postmenopausal, had a hysterectomy, she's gravida 3, para 2, associated history no smoking, drinking, or illicit drugs, and has a family history of paternal grandmother having breast cancer in her 60s, and mother that had ovarian cancer. She's not of Ashkenazi Jewish descent. The core biopsy of right breast mass is performed, and also of an enlarged right axillary lymph node. And the pathology shows invasive ductal carcinoma, grade 3, ERPR negative, HER2 negative, 1+ by immunohistochemistry, and FIS ratio of 1.3. And the lymph node that is biopsied shows also presence of metastatic carcinoma. In addition, I think in the scan for this patient, there were at least 4 lymph nodes identified. So although on the examination there weren't matted nodes, this patient had at least 4 or more lymph nodes potentially involved by imaging. And she had genetic testing results were pending at the time of presentation.
So this is a great tumor board discussion, not uncommon. I think one of the first questions for you, Dr. Mamounis, is when we consider the pure clinical staging criteria, they don't really count number of positive lymph nodes like they do in the pathologic staging. But is your intellectual mindset almost to treat them as if they have N2 disease or stage N2 disease?
Right. Yes. Yeah. Good point. Of course, is that typically the staging system calls N2 disease having matted lymph nodes, but sometimes now with imaging techniques we can see that the patient has 4 or more abnormal lymph nodes, and we tend to think that obviously if surgery took place, this patient will have an N2 disease pathologically. So we treat them as locally advanced. Certainly, there are higher risks for recurrence with this presentation for sure.
And in someone like this, clearly they have operable breast cancer. Is your thoughts to proceed immediately with surgery?
No, because not only because of the presentation of a large tumor with the lymph nodes, but also because of the phenotype. This patient has triple negative breast cancer, who is a breast cancer that we typically would treat in the neoadjuvant setting with neoadjuvant chemotherapy for multiple reasons. One of the main ones is to be able to observe the tumor and see how the tumor shrinks or disappears with neoadjuvant chemotherapy. Gives us important information in terms of the long-term outcome of the patient. From a local regional therapy standpoint, allows us to downstage the disease both in the breast and in the axillary nodes, and perform potentially a lumpectomy where a mastectomy would have been indicated, and more importantly, even perform a sentinel lymph node biopsy rather than an axillary lymph node dissection if we're able to sterilize the lymph nodes and find that they're negative at the time of surgery. So there's some clinical advantages of doing neoadjuvant chemotherapy. There are some practical advantages also. For example, somebody that has genetic testing and we don't know the results yet, and she can't decide whether she needs a mastectomy or wants a mastectomy or not. I think neoadjuvant chemotherapy gives us the option of getting everything together, all the pieces of information we need, and then make the appropriate decision. And also from a logistical standpoint, if she chooses, let's say, bilateral mastectomy because of the positive genetic testing, we'll have the time to refer her to plastic surgery, discuss different options of surgery, and have her sort of ready for her when she finishes her neoadjuvant chemotherapy. So there are many potential advantages of doing neoadjuvant chemotherapy, particularly for tumors that are actually very responsive to chemotherapy. And triple negative breast cancer is one of them. The other one, of course, is HER2 positive breast cancer. For those two groups of patients, whether they present with locally advanced or with large operable disease, our approach is to do neoadjuvant chemotherapy first.
And as you're discussing this case with Dr. Butler, your radiologist, prior to any chemotherapy, obviously, if they respond really well and the breast tumor is gone, how do you find it surgically? And in addition, when you're thinking of these abnormal lymph nodes, do you find it helpful to elicit the radiologist's help in identifying them with a permanent marker of sorts?
Yes, absolutely. I think that's actually what has made a big difference nowadays. Obviously, putting a clip in the breast mass has become the standard, and obviously we expect that. But also putting a clip in one of the involved lymph nodes is very important because we like to target that lymph node for resection when we do our sentinel lymph node biopsy procedure, assuming that the lymph node normalizes and other lymph nodes normalize as well. And removing the clip in addition to performing removing the clipped node after localizing the clipped node and doing a sentinel lymph node biopsy improves on our false negative rate of the sentinel lymph node biopsy procedure after neoadjuvant therapy. This is a concept that MD Anderson has coined as targeted axillary lymph node dissection. So we're not only removing the sentinel lymph nodes after neoadjuvant chemotherapy, but we also remove the clipped lymph node. And we localize them. Again, it was a little bit of a challenge to localize them with wires in the past, and sometimes you needed CT scans. Now we put, in our place, we put hydromark clips in the axilla that you can see by ultrasound, and you can localize them afterwards. And we typically do the same procedure, for example, a Savi-Scout insertion or radioactive seed insertion in the axillary lymph node, as well as in the breast, if we're going to do a breast conservation surgery.
So, Dr. Butler, I might ask your thoughts, and clearly when you do a biopsy, ultrasound guided biopsy, in this case, you'd leave a clip in the tumor bed. Do you try to put it in the center of the tumor, or do you try to put brackets of the original volume? And when you have lymph nodes that you have 4 abnormal lymph nodes, do you just pick one and put the clip in where you do the biopsy, or are you trying to sample all 4 lymph nodes? How do you approach this, Dr. Butler?
It's generally been our practice to place a single clip in the center of the tumor. And of course, we know that tumors respond differently to neoadjuvant chemotherapy, so that they sometimes fragment and other times shrink more concentrically. But it has been sufficient, and Dr. Mamounis can comment further on this if this is his experience as well. It seems it's been sufficient for our surgeons to have the one single clip, which we aim to place in the center of the tumor. In terms of lymph nodes, we also have only been biopsying one lymph node. It's generally the most abnormal appearing lymph node, and then placing a clip, also Hydromark, which is FDA approved in the axilla, within that lymph node, even if there are additional lymph nodes that look abnormal.
Thank you. Dr. Regan, what are your thoughts about systemic treatments for this? First, I assume that you'll be recommending chemotherapy. Do you like the idea of giving chemotherapy before surgery? And if so, what advantages from your perspective does that offer?
Well, I do like giving preoperative chemotherapy in a scenario like this. And I think Terry very nicely kind of mentioned why we do this. Really, it's from our perspective, I think the idea of being able to see if the cancer is actually sensitive to the treatment, because when you treat adjuvantly, of course, there's nothing to follow, right? So it allows you to kind of maybe tailor treatment a little bit as you start treating patients. So, for example, doing like a mid-chemotherapy imaging and then potentially changing your approach depending on the results. So I would definitely recommend preoperative treatment for this patient. I think the standard of care still is an anthracycline taxane based regimen. However, in a case like this with a locally advanced triple negative breast cancer, I would definitely consider firstly thinking about carboplatin, because we know that adding carboplatin with paclitaxel does increase the rate of pathologic complete response when there's no cancer in the breast at the time of surgery. And then more recently, we had a study showing that the addition of the PD-L1 inhibitor pembrolizumab to paclitaxel carboplatin followed by anthracycline cytoxin-based chemotherapy further increased the pathologic complete response rate. So I think in a high-risk patient like this, I probably would be inclined to take a pretty aggressive approach and actually think about using the pembrolizumab and carboplatin. One of the issues is we don't really have good data saying that pembrolizumab really adds to the taxane anthracycline regimens on their own. The study that we have also incorporated carboplatin. And the reason I mention that is that when you combine carboplatin and paclitaxel together, it has can cause quite a lot of neutropenia and thrombocytopenia, and you very often have to kind of hold doses of paclitaxel. But I think in a patient like this, I would take an aggressive approach. You could, I guess, make a case that you could maybe start with AC alone and see if she responds, and then consider whether to add in the carboplatin and pembrolizumab at that time point. There hasn't been really any clinical trials that have really shown the value of that approach, but there are some triple negative breast cancers that just melt away within a couple of cycles of treatment. So that would be another approach that you could potentially take, I think.
Do you ever use Abraxane? Is Abraxane ever indicated?
So it's not something that we typically use in this kind of, so it's not really an early stage, but neoadjuvant adjuvant setting. There is data with nab-paclitaxel being a little bit better than paclitaxel in one study for preoperative triple negative breast cancer, but then there was another study that didn't show it was any better. So I typically use paclitaxel, but if, for example, they had significant allergic reactions, then I would think about changing to nab-paclitaxel or Abraxane at that point.
And in general, does using neoadjuvant chemotherapy instead of adjuvant chemotherapy also give you some guidance as to whether they need additional chemotherapy in the adjuvant setting?
Yeah, I mean, that's another, I should have mentioned, that's another big advantage, well, somewhat of an advantage of doing this. So what we know is that in patients who have residual triple negative breast cancer, that if you give capecitabine for 8 cycles afterwards, those patients have a lower recurrence rate than patients that do not get that did not get capecitabine. So again, and there are a number of clinical trials in this space as well, looking at PARP, PARP inhibitors and immunotherapies in this setting as well for these patients. Because one of the problems is that, particularly in patients that have a poor response to chemotherapy and have a high, what's called residual cancer burden, their likelihood of recurrence within a short period of time is very high. So I think it does also allow us to kind of have a better perspective of the patient's prognosis. And based on the CREATE-X study, have the ability to think about using another agent in that setting.
And Dr. Piccini, do you like seeing these patients as they get started on their treatments, even though radiation obviously is not going to be an upfront component of their therapy? How, historically, someone with 4 positive lymph nodes would be recommended to receive regional lymph node or post-mastectomy radiation or some combination therein. But now you're going to have changed pathology by the chemotherapy. How are your thought process in this particular case?
Well, typically we would see these patients up front, right, alongside with the medical oncologist and the surgeon, and inform them that most likely trimodality therapy, meaning radiation therapy, will be integrated at some point. And we tell them we will tailor the radiation therapy based upon their response. But personally, I also like to monitor the response in the breast clinically with these patients prior to surgery. In other words, in the unusual event that the patient did not respond, I'd like to be on top of the situation with the medical oncologist. And in the unlikely event, administer preoperative radiation therapy, which is very infrequently. But nonetheless, yes, we like to see these patients up front. We like to advise them when the radiation will be integrated and telling them that doses and techniques will be based upon their response, which I'm sure Terry will discuss in a moment.
Well, yeah, both Dr. Mamounis and Dr. Piccini are important leaders of cooperative group trials, including the NRG cooperative group. They have a protocol in this setting. Terry, do you want to mention the B51 study and how a patient like this might become eligible for comparative of radiation questions after surgery?
Yeah, sure. So the NSABP B51, also RTOG 1304 trial, is a trial that came out of observations that patients that had positive lymph nodes receive neoadjuvant chemotherapy and the lymph nodes become negative surgically at the time, have a lower rate of locoregional recurrence than if the nodes were remaining to be positive. So that has gotten us to think whether we should be treating these patients as node positive, which they are at presentation, or as node negative, which they are at the time of surgery, or they may be somewhere in between. So the big question, of course, is now, is radiation beneficial for these patients? Because on the other hand, we know that radiation is beneficial for patients with positive lymph nodes if they're treated in the adjuvant setting, but it's not so beneficial in terms of decreasing mortality for patients that are not negative. It does decrease local recurrence, but it doesn't affect the survival of patients if they're not negative. So this is the situation that we find ourselves to by using more and more neoadjuvant chemotherapy. So the B51 trial essentially randomizes patients that have positive nodes before neoadjuvant chemotherapy, but they're found to be negative at the time of surgery, either by a sentinel lymph node biopsy or axillary dissection or both, and then randomizes them to either comprehensive radiotherapy or not. Now, if patients have breast conservation, they all get breast radiotherapy, and the randomization is between regional node radiotherapy or not. And if patients have mastectomy, the randomization is between no radiotherapy at all or comprehensive chest wall and regional node radiotherapy on the experimental arm. Or now that it's not really technically, we're seeking the trial to see if radiation will improve outcomes, but outside of the clinical trial, I should say, most of these patients will receive radiotherapy if they do not want to participate in this trial. So although it's a superiority trial trying to see if radiation will improve outcomes, technically the standard of care is to radiate these patients because they're not positive if they don't want to participate in the clinical trial. And I'm pleased to inform you that this trial is about to complete in another 6 months. It took us quite some time to actually accrue our target sample size, but we almost about less than 100 patients till we complete accrual. So very important trial.
Fantastic. Good to hear that. Congratulations, Jerry, to you and the breast cancer group. Back to Dr. Bassini. Frank, if this patient did undergo a sentinel lymph node procedure at the back end, say it was in keeping with the mastectomy, and the sentinel lymph nodes were positive, That would be an indication where you'd be thinking radiation needs to be part of the treatment. Do you think that Dr. Mamunis has to go back and do a dissection, or can you use radiation as an alternative to dissection? I think
Sure.
there's another cooperative group study looking at that issue too.
Right. There's another study looking at that direct question, but each of those cases we take individually, and assuming there's minimal disease remaining with the sentinel lymph node, typically I will tell the surgeon that I can't comprehensively treat this patient and they don't need to add the double morbidity of axillary dissection. But still to this day, I would say, and Terry can comment on this, I think many institutions that are still offering axillary dissection. And I think you're referring to the ACOSOG study that is looking at that very issue as to whether or not axillary dissection is necessary or whether or not we can just treat with radiation therapy. And I think as Terry has pointed out across the country, it does vary in terms of how these patients are managed. And so both of these trials, the trial that Terry is the PI on, where the patients, if they undergo a complete pathologic response, are randomized to regional nodal radiation or no radiation, or the ACOSOG trial, whether or not they get axillary dissection or radiation therapy. I think both of those trials will really help us to better tailor the radiation therapy to the regional lymphatics and reduce the morbidity. I don't know, Terry, if you want to comment on that as well.
Yes, yeah. So I think we have a lot of information, as I mentioned earlier, about the role of radiation when surgery up front is done, and the nodes are one or two nodes are positive. We don't have a lot of information on what the effects are after neoadjuvant chemotherapy. For example, in somebody like this who had 4 positive nodes, if now there is residual disease in the nodes, I think the standard is still to perform an axillary lymph node dissection. Although I must say that again, looking around the country, the situation of having 1 out of 3 positive nodes or not 1 out of 4, and people not wanting to go back, I think is more common than we like it to be, given that we don't have a lot of information. But certainly in that case, we always rely on radiotherapy to do what radiotherapy usually does, is to clear micrometastatic disease in the nodes, in the surrounding nodes. But until we see the results from the trial, I think performing a completion axillary dissection is something that I would typically recommend for a patient like this if she still had positive nodes. And most of the also post-neoadjuvant chemotherapy trials or immunotherapy trials require a completion axillary dissection, because unless the patient participates in the ACOSOG 12202 trial, which is a trial of comparing completion axillary dissection versus not, provided that radiotherapy will be given.
So I think just to conclude, the good news about that Alliance trial, randomized trial, similar to the NSABP study, it's accrued very well nationally. And it met its original accrual goal, but then was expanded. And so it's reopened for randomization versus completion dissection or using radiation as an alternative to treat that component of the axilla in addition to the other areas where the radiation is targeting.